Okay, it's a little bit more noisier when we have lunch with it, but if you'll stop just for a second, I'd like to introduce. Is it not working? Can you? Yeah, okay. Now, can I read my thing? Okay, let it. Uh, okay. Well, it's indeed a real pleasure to me to introduce things and enjoyed meeting each other and talking about what we're doing and at all kinds of meetings over the year. So that and The speaker is Dr. Bertha Madras, and she's professor of psychology at Harvard Medical School and with an office in the McLean Hospital. Before joining Harvard Medical Center, she earned BS, PhD from McGill, did postdoctoral work at Tufts, Cornell University Medical College, became a research associate at MIT, and assistant professor in the Department of Psychiatry at the University of Toronto. Uh, Probably more what you know and what is more important is that Dr. Madras was recently served as President Trump's commission combating drug addiction and opioid crisis. And you probably know, and maybe I should have invited him. I told Bertha, our governor. She served with our Governor Cooper, who was also on that commission. And before that, Dr. Madras was Deputy Director of Demand Reduction for ODNCP on the control policy. That was a nomination by President Bush. And if you've read her things, how many people you know that unanimously was approved by the Senate, and and she has that distinction. Uh, it is also let's see. Oh, Her research studies is focusing, as you might expect, largely on addiction, but Parkinson's disease and attention deficit hyperactivity disorder. And these studies in her laboratory led to a very important and useful and valuable imaging agent, ultrapain, which has been used for neuropsychiatric studies. And she's also, like what we do here, has developed treatment drugs that were designed for and went well on the way as a potential pharmacotherapy for treating substance abuse. Uh, and I think it's worth mentioning, if you haven't done it already, that as you might expect, from what I've described, it eats up a lots of her time. But somehow or another, she found time to creation of a museum exhibit uh, licensed to Disney Corporation. It plays at the Museum of Science, Boston, titled "Changing Your Mind: Drugs in the Brain." So if you haven't done it, you may. I think you can go Wayne or Bertha knows where I've got a copy of it, so I can look at it. But these research accomplishments, as well as many others, have been recognized by NIDA Public Service Award. And I think maybe if it wasn't the first one, it was close to the very first one that NIDA awarded. Uh, she had a NIH Career Award and a very prestigious College on Problem Drug Dependence, Marion W. Fishman, and as well as, and I'm not going to take up any more of her time. She's an outstanding scientist. You saw what I wrote in the announcement. It's out there. So I'm not going to take the time to go through telling all of what her accomplishments are. But today she's going to tell us something about the opioid crisis, made in America, fate in America.
Thank you very much for being here. Can everyone hear me? Great, wonderful. It's quite a leap from going from basic science into public policy, and it's a career path that I have never anticipated nor worked towards. Most of these opportunities arose with a phone call that was a cold call to my office. And with regard to the ONDCP position, just anecdotally, I had a friend who one day called and said, Bertha, I'm calling from the White House. I need some help. And he was joking. He disguised his voice. This was Philip Seaman, who I've collaborated with. And I said, oh, Phil, I can recognize your voice. 2 weeks later, I get a call saying, this is the White House calling. And I was about to say, and I hesitated and I said, this doesn't quite sound like his voice. And it turned out to be an offer to serve the country. So these things happen serendipitously in life, and sometimes they offer tremendous opportunities. The work on the Opioid Commission was one of them. These are my disclosures. Most of these have no financial connections whatsoever. It's just a list of some of the organizations I've worked with recently. For those of you who are uninitiated, and there are many outstanding chemists in this room, including Ivy Carroll, who's I've known for literally 30 years or more, and he has, we both agree that we'll call each other 100 years old, and that takes care of all the plus and minus in our age ranges. But Wayne, I'm deeply grateful to him because I called Ivy when I was doing this museum exhibit, literally on a dime. And I asked Ivy if he knew somebody who could do molecular modeling of neurotransmitters along with drugs of abuse. And Wayne just got back to me in 5 minutes and developed some of the most beautiful animated models which went into the CD and went into our exhibit. So thank you so much. Thank you, Ivy. The ancient Greeks had a term. I don't know how many of you love history as I do, but the term was pharmakone, and pharmakone meant both a medicine and a poison. And I don't think of a more apt description for opioids than pharmakone, because opioids can produce both pleasure and alleviate pain, and sometimes provoke tremendous pain in individuals, the pain of addiction and uncontrollable use. They're very effective in pain, in pain killing properties. They also have tremendous euphoriant effects in susceptible individuals. And as we are all aware, pain is the #1 self-reported reason for people using drugs with abuse potential. And one of the interesting things is because pain has so many, it has a physiological, a psychological, and emotional component. Relieving pain can sometimes be relieving emotional pain as well. What I'd like to do in the next period of time is describe the opioid crisis briefly, the root causes of it, the Commission recommendations, some of the lessons that we have learned over the years. The United States has the dubious distinction of leading the world in terms of opioid prescribing. Of the 30 countries with the highest opioid prescriptions in the world, we are by far #1, with Canada running a short second. And on average, we prescribe 5 times more opioids than any other nation that actually prescribes them. And the question is, does the United States have more pain than any other country? And the answer is no, it doesn't, because that has actually been quantified. So we are not a pain-producing nation, but we are a nation of consumers of pain medication. We also have the dubious distinction of leading the world in terms of opioid overdose deaths. Little Estonia had a problem in around 2012, and it got rid of it very rapidly. But no other country comes close to the US. In terms of the most recent data from the CDC that have been confirmed, unfortunately, our data analytics at the federal level is so weak that we have to wait sometimes 2 years to accumulate and to verify information that should be available in close to real time. We had over 64,000 deaths in 2016. Of those, 40,000 plus were due to opioids. Prescription opioids were leading the way for a number of years, and now their rate of increase is declining. Heroin's deaths are more than prescription opioids, and fentanyl is by far the cause of most of the deaths in terms of the number of deaths compared to all the others now. What that means, of course, is that the scenario has shifted from prescription opioids into having a balanced program of supply and demand. Now, in composing the Opioid Commission report, one of the things that I felt was critical was to look at the root causes of how we got to where we got. Because if we don't understand the root causes, not only can we make recommendations that can reverse engineer some of the root causes, but by looking at the root causes, we can develop preemptive activities and actions and regulations and mindsets that will prevent a recurrence in the future. So what are some of the root causes? How many of you in this room are aware that in the 19th century we had a dreadful opioid, prescription medication, iatrogenic opioid addiction problem in the US? By a show of hands. Well, it looks like it's probably less than 20% of the people present. What is so interesting about it is that I've started to excavate the literature in the New England Journal of Medicine, and what you can see are physicians writing in the 1920s about iatrogenic addiction, about the problems of trying to wean people from morphine. This is 1828, trying to wean people from morphine, and past a certain level of tapering, they can't go any longer, and the patient remains on a morphine and is incapable of functioning without it. And then we have also articles in 1923 and 28 of people trying to develop overdose remedies for opioid overdoses 200 years ago. And some of these overdose remedies were vinegar, acetic acid to make people vomit their stomach contents. Another one was a tube with a bulb at the end to try to go into the gastrointestinal tract and extract the opioid from the GI tract 200 years ago. And what happened about 100 years ago after the epidemic waned was a development of opiophobia, a tremendous fear of opioids among the medical community. Due to regulatory and legislative initiatives, physicians were no longer allowed to prescribe morphine and other forms of opioids in order to maintain a person in the addicted state who could not wean themselves off. So the first problem we had is generational forgetting. People ignored a lot of this early history in medical schools, and we'll try to see what the triggers were. There was a weak appreciation of what I would call quality science. There was very little education on pain management and opioid prescribing. In 1995, one of my colleagues at Harvard Medical School enlisted me in a course she was developing on pain management an elective course because she and I both felt that pain and opioid prescribing and pain management was a looming problem. And of the 400 plus medical students eligible to take this course, how many enrolled for 2 years in a row? 2. And then I stopped teaching basic opioid receptor pharmacology because I felt that for 2 students, there's so much preparation involved. And we also had a disconnect between addiction medicine services and the medical community. And one of the reasons for that was because as physicians could no longer treat people with addictions with opioids, they felt that this is a separate category, a separate population, and there grew a giant disconnect between rehabilitation centers and the healthcare system. And there was very minimal training that overlapped between the two, so that physicians were not well trained in dealing with this. For decades, prescription opioids were avoided because of fear of addiction, of overdose, and also the fact that there wasn't good science that they're effective for chronic use. When I was at ONDCP in 2006, I knew this was an issue, a very important one. And I scoured the literature myself as I would do from about 5:30 when everyone went home till about 11:30 at night in my office when I would go home. And I would look at the literature and say, how many papers are out there that look at the administration of opioids in randomized controlled trials, administration for more than 3 months? And there was none. There was none. So we had no data, and yet by that time people were being prescribed opioids for all forms of pain for indefinite periods of time. The pressure for pain management with opioids began to mount. First of all, there was a shift to blame the provider. If a patient has pain, they have to be treated properly. And a number of pain physicians began to advocate for treating of pain with opioids. Then there was a patient advocacy movement that joined in, and they began to advocate. Then the pharmaceutical industry poured millions and millions of dollars into promoting and educating patients, physicians, pain societies, medical societies on the use of opioids for pain management. One pharmaceutical company sponsored 20,000 plus events across the country. They also sponsored detailers, doctor detailers who would come into offices on a one-on-one basis to educate physicians. By 1998, the Veterans Administration adopted pain as a fifth vital sign, along with heart rate and blood pressure and respiratory rate and temperature, and pain became number 5. And they mandated pain evaluation in every patient. By 2000, the Joint Commission that accredits healthcare organizations also adopted pain as the fifth vital sign. They assessed pain, they mandated the need to assess, to treat, to make sure that patients were satisfied with their pain management. And the pain satisfaction scores became used to accredit healthcare organizations and for reimbursement purposes. So there was tremendous pressure on physicians to address pain with opioids. And in every physician's office, in every hospital, these little smiley and unhappy faces showed up with a focus on pain management and increased pain medications. The healthcare community Their feet were under the fire with regard to inadequate medical education, on quality science, on pain, on opioid prescribing and drug addiction. And let me just divert for one moment on quality science. One of the great triggers of this movement, which empowered the pharmaceutical industry, which empowered patient advocates, was a 1980 letter to the New England Journal of Medicine, a letter to the editor. It had 5 sentences in it, and the title of it was Narcotics Non-Addictive for Pain Patients. I gave that 5-sentence letter to a medical school class that invited me to speak just a few weeks ago, and I asked them to read this 5-sentence letter and said, can you find out what the flaws are in this? And within 10 minutes, they picked out the 5 main flaws. But somehow, during that period from 1980 until 2017, very few people actually discussed the flaws. And the reason I say that is that during that period of time, there were 600 citations of that 5-sentence letter to the editor. 600. And the vast majority affirmed the conclusions of a 5-sentence letter to the editor, that opioids are not addictive in patients that have pain. So there were no guidelines for how to treat chronic pain and no guidelines on using prescription opioids versus options. Pain became a 5th vital sign. The patient movement grew without patient-informed consent on the hazards of these drugs. The Centers for Medicaid and Medicare Services discouraged the use of non-opioids for pain treatment because opioids were inexpensive, they were not labor-intensive, they were a quick fix. There were other financial incentives, and I won't get into all of these, but these were ways of evaluating pain management in patients. And there was firewalls between people's records for addiction treatment compared to their medical records. The FDA was languid during this period. And as prescription opioids tightened, heroin and fentanyl began to raise their head. And one of the ways in which it reemerged was that it was being marketed in regions where there was high levels of prescribing of prescription opioids. Along with that came tremendous barriers to treatment of pain patients. There were barriers to medications-assisted treatment, like methadone, buprenorphine, naltrexone, and there were barriers just to treatment, to reimburse treatment itself. Opioid prescribing increased dramatically, it increased between 3- and 4-fold. And during that period of time, let's see if I can maneuver this. I have these wonderful animations, but without a mouse, I can't do it. In any case, currently, there are about 12 million people who misuse opioids, about 2.5 million people who have an opioid use disorder, approximately 600,000 with a heroin use disorder, and all of these are considered underestimates. These are NISTA reports. I don't think there's any question that these are underestimates. There are many pathways to prescription opioid use disorder, and amongst those are inadequate pain control. People escalate the doses. Likability on initial exposure for pain relief. People report that the first time they were exposed to opioids, they felt much better and very different, and they felt very pleasant. Many people do not. They have an aversive reaction. They feel nauseated. They may vomit. But there is a subpopulation that clearly is susceptible to the positive reinforcing effects. or some people wanted prescription opioids just to use for psychoactive purposes without having any medical condition. There are other people who wanted them to relieve themselves from emotional distress, and many women who were addicted to opioids in the 19th century presented themselves to physicians because they were anxious, they were stressed, they couldn't sleep, and they were prescribed opioids. People who have had a prior history of opioid use disorder or other substance use disorders were also much more vulnerable to the consequences. In 2005, about 90% of people entering treatment for heroin addiction had started with prescription opioids. 10 years later, that number has fallen to 67%, which means more and more people are initiating opioids that are heroin or fentanyl and not prescriptions. So the prescription pipeline to heroin is declining, but it still represents a very significant problem with regard to the population. And then we had a perfect storm. This is fentanyl compared to a US copper. People in this room don't need these analogies. They know relative doses of fentanyl versus carfentanil versus heroin. These are lethal doses and they are remarkably low potency. And we had the perfect storm. A large population addicted to prescription opioids, tamper-proof medications coming in the market that prevented IV injections, along with a declining number of physicians willing to prescribe high doses or for long-term use, and a market of heroin and fentanyl with more pure heroin coming on, with at lower prices, along with fentanyl being produced largely offshore or in Mexico, and so the storm continued. The president appointed 6 people to the commission. You can see Governor Roy Cooper standing beside Patrick Kennedy. Governor Christie was the chair of the commission. Governor Baker of Massachusetts was standing beside this 100-year-old lady. We were sworn in at the time, and we generated a report of about 130 pages within a very short period of time. What was the charge of the commission? We were charged with understanding what federal funding is currently available for drug addiction and for the opioid crisis. What is available in terms of addiction treatment and overdose reversal, in terms of availability nationally, regionally, and what are the stumbling blocks to accessing these services? How can we produce a form of prevention which includes both supply reduction as well as education and information to the public? Prescribing practices are a form of prevention. Prescription drug monitoring programs are a form of prevention, and reducing the pipeline of fentanyl and heroin, all of these are forms of prevention. We were tasked with looking at the effectiveness of educational messages and also looking at what are federal prevention and treatment programs currently available and make recommendations to the president to improve the federal response. Governor Christie asked me to shepherd the final report. It was a labor of love, I can assure you. By July 7th of 2017, I had 253 titles on my computer for the structure of the report. That was about 3 weeks after we were sworn in. And I emailed them to Governor Christie, And he said, and he endeared himself to me for life. He said, "Hey, kid." Now, when you're called kid at this stage in your life, that's a compliment, folks. When I was a teenager, I would not have accepted it. He said, "Nobody's going to read a report of 500 pages with 200 topics. We have to simplify. We have to really tighten it up and make things that are reducible to practice." And I said, well, let's see if we can make it reducible to practice in terms of the short term, intermediate, and long term. And so we went forward with it. And this is a very elementary form of systems analysis, looking at where we have to intercede in terms of prevention, in terms of reducing prescription opioids, in terms of reducing the supply of heroin and fentanyl, and also the supply of fake pills, which is a massive problem because pill machines are being shipped from overseas, primarily from China, and they are being pressed with the logos of legitimate pharmaceutical companies. And some of them are being marketed as benzodiazepines, some of them are being marketed as cocaine, some of them are being marketed as heroin, and many of them have fentanyl in them. There is a story of a news anchor who no longer is, but his son was on the campus of the University of Colorado, and he was anxious. A friend of his offered him what they both believed was a benzodiazepine. And he died that night because the fake pill had fentanyl in it. I've heard too many stories like that. I've heard too much that right now, quite frankly, my brain hurts from all this information because I have heard too many personal stories of how young people inadvertently are dying, how older people advertently are dying. They are essentially using fentanyl knowing it can kill them, and in some cases, we don't know how many, it's estimated 30% are essentially using them as a form of suicide, of self-destruction. We looked as well at the risk factors, the environment, the individual, and the drugs, how people initiate these drugs. And at each step of the way, an overdose is possible and rescue is essential. Dose escalation, addiction, withdrawal, relapse, treatment, abstinence, recovery, lifelong abstinence, and the impact on families, on children, on health, on safety, the costs, productivity, all of these things. But we essentially wanted to look at what we can do rather than what we can theorize, speculate, or pontificate about. And the recommendations fell into broad groups of prevention, treatment, rescue, recovery, research, and who's going to do it, and above all, accountability. And one of the recommendations that I strongly made, which was not accepted, is that in many cases we need contracts rather than grants for these, for some of the federal funding. And the reason is that with a contract, it's a binding legal document that says if you don't have 10,000 treatment slots in this community, you will create so many by such means, by such levels of training and so on, by this and this date, and be able to recruit into the treatment program so many people in need. The same is true for medications, assisted treatment. The same is true for naloxone rescue. And I felt by having binding contracts, we would have accountability, metrics, outcome measures, rather than block grants. And I lost that battle. But I still won the battle of accountability. The final report came up with 56 recommendations. And one of the ones which I felt was very important was to streamline the funding. There are all these RFAs and block grants and little grants and bigger grants that are available in a mess, in a maze. And each one of them has different requirements for acquiring the money. They have different requirements for outcomes. And I felt this is just madness. If we just systematize the opioid problem as a standalone and just have a single type of grant, that could make it a lot easier for states and other types of providers access the money without this maze of which grant would suit which one and what the regulations are. And it would also make it easier to track. And then we had prevention. We looked at multiple levels of prevention in terms of individuals, youth, national media, in terms of educating patients. We looked at prevention as a form of supply reduction, and the Department of Justice was heavily involved in composing this component, which occupied approximately 4 pages of the total. We had another form of prevention, which was patient-physician education, alternatives to opioids, prescription drug monitoring programs, and pain management. We had a segment on data analytics, the absolute need for real-time data, for data that would help understand where are the greatest pockets in need, what are the drugs that are being involved in overdose deaths. Are people dying alone? Because if they're dying alone, there's no point in distributing naloxone. For example, in New Hampshire, 75% of the people in 2017 who died of an overdose died alone. Who's going to call? What friend, what family, what first responder will show up if nobody's aware that that person is dying alone? And one of the problems that we thought about is that the heroin use currently is different than it used to be. It used to be somewhat a gathering of people. Nowadays, it's not. There's far less of a social milieu that's involved in its use. It is more associated with lone sole use. We looked at barriers to treatment in terms of quality of treatment, which is critical. And the US has an abysmal level of treatment quality. We looked at insurance coverage. Why are there so many obstacles to coverage? Mental health parity laws are not being adhered to. We looked at how many treatment slots, the staffing, how to increase the density of staffing, the availability of medications-assisted treatment, and all of these issues with regard to people in the criminal justice system and how to improve the response to them. We looked at barriers to rescue. More than 10 years ago, when I said just handing out naloxone to everyone is a problem because without a follow-up, people will die or they will repeat overdose. I was called Dr. Death in some lay publications because I said they quoted me saying, I don't want people to be rescued. Nothing could have been further from the truth. My feeling was it was the equivalent to having a person have a heart attack in a shopping mall and somebody opens the case with the paddles, resuscitates the person, gets them into a normal heart rhythm, and then just leaves them on the floor and walks away. And that was what was happening in our system throughout the country. People would inject the naloxone and walk away. They'd inject the naloxone in emergency departments, and as soon as the patient woke up, they'd let them walk out. No records, no follow-up, and I felt that that system is going to lead to more and more deaths because that person is one dose away from dying. And then we looked at recovery support services in terms of all these factors: housing, employment, colleges, families, children, and research, the necessity of research, better medications for pain management, for assistance, for treatment, overdose rescue, and devices. President Trump accepted all 56 recommendations and some of the recommendations I'll just summarize quickly. We looked at the analysis of some of the earlier media campaigns, the fried egg on brains campaign of the 1980s, and decided there are other ways of attracting the attention and getting to young people who use now social media much more than watch television commercials, and thinking about all the ways in which we could approach and attract them through modern methods of communicating. We looked at modern methods of conducting screenings in schools and in other venues for youth, because there are evidence-based sets of screening tools that are available on iPhone apps that have a reasonably high level of fidelity. And young people are more willing to talk to an iPhone screen than they are face-to-face with some people. And those side-by-side comparisons have been conducted. We looked at all the factors that hampered the healthcare community from administering opioids properly and all the pressures on them. And we made many recommendations to reverse engineer the types of pressures on the healthcare system and on physicians and free them from the shackles of these kinds of pressures, including patient evaluation and pain, including the pain as a fifth vital sign, and so on and so forth. And then we looked at some of the problems with the healthcare system, the lack of compliance with mental health and addiction services parity laws. This parity law was passed in 2008, was signed by the President Bush at the time, which said that people who are treated for mental health and addiction the people administering the treatment should be reimbursed at the same rates as the rates for physical problems. And what we found is that these parity laws are not being implemented, and we looked at mechanisms by which they can be implemented. We looked at mechanisms to reimburse the true costs, which is part of the parity system. We looked at quality outcome measures. We have 14,000 treatment centers in the United States for addiction. Many of them do not offer medications assisted treatment. Many of them have a philosophical aversion to medications to treat addiction. Many of them do not have AIDS or hepatitis C counseling or testing. Many of them do not have mental health screening or a psychiatrist who can help deal with mental health problems, because the overlap between mental health and addictions is so powerful in so many ways. And less than 30%, as I said, offer medications assisted treatment. I once did a project for NIDA. I was on a committee that said, why aren't mechanisms of evidence-based treatment being translated into treatment centers in the country? These principles are out there, they're available on the web, they are taught in a number of different venues. Why aren't they being implemented? And so I said to the committee, before we even begin to ask this question, let's ask the primary question. how many treatment centers are implementing and how many are not. And I developed this lengthy table, and I scrutinized all the data on 14,000 treatment centers and compared them to principles of evidence-based treatment. And so a minority of these treatment centers conformed with these principles. And then the next question was, how can we influence that and improve that? And of course, one of the ways is by reimbursements. If you develop quality outcome measures and say, we're not going to reimburse you if you don't do what is evidence-based and your outcomes are reasonable and within the boundaries of outcome measures for the best centers, then perhaps you shouldn't be in business. We looked at recovery coach training. What does that mean? It means that when a person overdoses, instead of leaving them right after naloxone is administered, there is a person there that says, let me help you. I can get you into treatment, and I can offer you medications right now with a physician's prescription, and we can do this. And we asked for treatment on demand, which is treatment availability within 24 hours. We looked at quality standards and also recovery residences. That is a terrible problem, because there are fraudulent recovery halfway houses with no standards whatsoever in some places where drug use is rampant. And we said, let's improve that. We know that there are medications, I'm sure many of you are familiar with them, but look, as I said, less than 35% of the treatment centers offer it. 60% of rural counties lack a physician with a DEA waiver, and many who are able to prescribe buprenorphine, for example, will not exercise that ability. They've taken the training program and they don't. They don't take the patients that are in need. We looked at patient education. We concluded that patients have the right to know and the right to refuse opioids. And a list of I've taken this slide to groups that are composed of public audiences. And I've said, how many of you are aware that these are opioids and there are reported deaths for every single one of them? And maybe 5% of the audience raised their hand. There's a tremendous need for patient education. We looked at, in many discussions and with NIH, we looked at what the research needs are, alternatives to opioids, improved opioid use disorder medications, improved rescue drugs, because some of the current antagonist that's widely used is inadequate to reverse a fentanyl or carfentanil or any of the 15 other fentanyl analogs that have been confiscated by the DEA. That reversal, some cases it takes 12 doses of naloxone to reverse, in other cases 3 or 4. But if a person goes home with a single dose and thinks they are reassured and feels comfortable, it's not a comfort level if they buy a pill that they think is cocaine and it's laced with carfentanil, or usually fentanyl. We looked at medical devices. One of the science fiction ones, which probably can be reduced to practice, is a ring or a device around an ear that measures blood oxygenation levels. It's available now. But if it monitors that oxygenation is low, it can trigger a signal to a first responder, or, which has not been developed yet, it can auto-inject naloxone to that individual. And that's especially compelling when people are alone and there's nobody around. We also ask that the FDA fast-track approve, promising how to alleviate stigma. Many people don't show up for treatment. Many families find out their family members have an addiction to opioids from a coroner, from a medical examiner. The first time they know about it, they see their relative on a gurney who's perished. And it's because many people do not want to share this information with their primary care physician. So what I would like to do is conclude with some lessons learned. What happened and what can we learn about it in the future? We know without a shadow of a doubt, and it continues to this day, that vast, vast sums of money were spent to promote opioids as safe, effective, and non-addictive for chronic pain. Millions upon millions of dollars were used to sponsor educational events, and some of the foremost medical associations in this nation took the money. I have a list of all of them. Some of the foremost, I'll repeat that, medical associations, and it helped in some ways to shape their policies. The opioids were promoted for many medical conditions, many pain conditions, even though pain is not pain is not pain. There are so many different forms of pain. Nobody treats migraines with opioids. Chronic lower back pain can be treated in some people as effectively with non-steroidal anti-inflammatories as they can be with opioids. There's a new report out that post-surgical pain can be treated as effectively with NSAIDs as opposed to opioids. They were promoted ubiquitously for all forms of pain, promoted as safe and non-addictive without the scientific evidence for chronic use. Advocates received the attention, patient advocates, but the opponents, the caveats. I checked the literature on oxycodone, for example. During the 1960s, there were a number of reports that oxycodone is highly addictive. It was well known by then. And there were many voices, not many, but voices that said, this is not a good thing because these drugs are addictive. And even if they are, and especially if they're extended release formulations, the bolus of drug can be much higher. And if it can be dissolved in an aqueous medium, it can be injected and get a very significant high. Even tamper-proof or abuse-deterrent medication formulations can still promote addiction because all you need to do is take more pills than prescribed, and there is enough that will get into the brain. What was not anticipated by the FDA was that addiction and diversion would occur, especially and including diversion because we had so many opioid pills. By 2006, 7, and 8, when I was at ONDCP, there were 9 billion pills prescribed every year for every man, woman, child in this country. I mean, meaning 30 opioid pills for every single person in this country. Now, there were 90 Percocets prescribed for a molar extraction. Most of the pain after a tooth extraction lasts 1 or 2 days, maybe a little bit more, but it's not acute after that. What do you do with 80 pills? What do you do if you have a sprained ankle and you're prescribed a month's supply, and the pain disappears within a few days. This is what was happening, and people were raiding the medicine cabinets to remove these excess pills. People were going to physicians to buy opioids for back pain which they didn't have and sell them on the street for between $60 and $80 a pill. The nation was so awash with opioids, unnecessary opioids, that we ended up with a problem that we're going to take quite a while to defeat. Illicit drugs flooded the nation, and medical education lagged far behind, and government regulations clearly failed to protect the public. Our oversights in terms of chain of custody, production quotas, prescriptions, scheduling, none of that helped, because physicians have the final say on the prescription. And if they're over-prescribing because of lack of education, lack of constraints, it's an open-ended market for these drugs. So I'd just like to close with my final statement. We've seen many people in the media, in the entertainment business, when their death occurs because of opioids. Michael Jackson, Prince, Anna Nicole Simpson, Marilyn Monroe, heaven knows the list, John Belushi, we can go on and on. There's so many eulogies and discussions about them, but it is estimated that hundreds of thousands of people have died of opioids. And alas, for those who never sing but die with all the music in them. Weep for the voiceless who have known the cross without the crown of glory. Oliver Wendell Holmes, Sr. Thank you. Yes.
That was a really great presentation.
Thank you.
I found myself shaking my head at the end when you were going through this. I mean, does nobody remember laudanum and the 19th century and the 20th century and all of the addiction that went on then, not to mention the 60s and 70s with heroin? So you started off by talking about generational memory loss. And I started to believe as you went through this that this was willful ignorance. But is it really criminal misrepresentation at the end of the day? Because to believe that these are not addictive drugs, nobody could ever say that they didn't know that.
Well, some of the pharmaceutical companies have already paid $600 million for misrepresenting safety and non-addictive properties. But right now we're seeing another wave of legal of lawsuits and legal actions that are being considered among states and including at the federal level in terms of these pharmaceutical companies that have been promoting these drugs as safe and non-addictive for chronic pain. There's no question in my mind that some people need opioids for the long term. There are, and it may not be opioids, but there are people who suffer tremendous pain, debilitating pain, pain that leads to suicidal thoughts, that simply disable them to an extent where getting out of bed, facing a day with pain is incomprehensible to those of us who have minor pain issues. We have to find better options for those. And we really think about RTI, Ivy Carroll, Wayne Miscarella, all the others who are excellent chemists. And I charge you to do something to help. One of the things that we're seeing in terms of, and it's part of my talk later on, a research talk. One of the things that is beginning to emerge, to surface, is that receptors, we've heard of this for more than 2 decades, but receptors can form homo and heterodimers. They can complex together. And when they do, their pharmacology is quite different than the pharmacology of the individual receptors. And there are 2 examples that have been brought to my attention in the past few weeks that seem to show promise in terms of developing a pharmacology for those heterodimers that may have far reduced respiratory depression, far reduced addictive potential. And I think there are many new pathways that we can think about. NIH is ferociously committed to drug discovery in this area, and they've just announced $500 million that's going to be expended in FY18 in order to promote the development of alternatives. The non-steroidal anti-inflammatories are marvelous drugs, but they also come with a cost, as every medication does to susceptible individuals. Ibuprofen can cause kidney damage, Tylenol can cause liver damage, but if used in modest amounts and not for 30 years, they seem to help enormously in some people with pain. But it's not enough. We need more and more and different approaches in terms of pain management.
We have a question online a moment from Catherine. She asks, what do you see as the potential role of the pharmaceutical industry to assist in addressing this epidemic?
That's a difficult question for me. And it's because I have been involved in discussions on a committee at NIH on private-public partnerships and what the future is. So, in fact, I do believe the report on our committee will be issued at 4 o'clock today on what the conclusions are in terms of the future. So I prefer to wait until it's public domain.
Did the Commission address, until there's something better, the rising cost of naloxone to the small towns in America, who it's bankrupting some of the small towns because the price has greatly increased also? Well,
as you know, I believe, and I have to simply get the final budget numbers, but Congress allocated $3 billion for FY18, which ends September the 30th, and the President has asked for $10 billion for next year. And part of that money is clearly targeted to developing much broader dissemination of naloxone, as well as medications, assisted medications for treatment, as well as treatment slots. A lot of it is the so-called demand reduction component.
Another question from online. This comes from Jennifer. She asked, has the connection between childhood trauma and later in life addiction been considered? And if so, how is the early childhood community being engaged and supported?
It's an excellent question. We address that in terms of support for families. We have a section of recommendations on how to support families that have parents with addiction and so on. But there are programs that are grassroots programs that are growing up in the country that are providing intensive support for families with high risk for their children. High risk in terms of pregnant women, high risk in terms of family environment, and the risk for the child to progress to substance use. One of the things that I think is critical to bear in mind is that the federal government with all the money at its fingertips, cannot solve many of these problems. Behavioral change, medical education. In some cases, you cannot force people to do what is the right thing. And so many of the solutions lie within each of us, within our communities, our families. So there are official programs to address children at risk. It's very clear that children who've been traumatized with physical, psychological, sexual abuse, who've been neglected, have much higher propensity to use drugs, and especially opioids in later life. There's a comorbidity with depression amongst these people. So much of this requires a different outlook amongst our culture. One of the things that I've said is that we've become a nation of chemical coping and chemical reward. We've normalized these. And we have to begin to think very clearly, is chemical coping and chemical reward, is the cost benefit of that really in terms of the ways in terms of the side of benefit? It doesn't, because so many people in the end have problems associated with chemical use, substance use. And that, to expect from on high the word to come down and change everybody it's not the way our country works, and I think we have to have a lot of solutions at the grassroots level. I've gone to medical schools and I've talked at length at what they can do to patch up the deficiencies that they've had, to many medical organizations, the Accreditation Council for Continuing Medical Education, what role they can play. There's so many organizations that can help and that can evince and evoke a cultural change that can change medical practice, change social norms and social values with regard to substance use.
With the data 2000 and the raising of the amount of people that you can serve with medication addiction treatment, is there any thought that there could be some exceptions made? I work in a rural clinic. I have 57 clients on medically assisted treatment, but I can't do any more because I don't have anybody else that has numbers that I can have. Is there, like nurse practitioners, could their numbers possibly go up? That is something the federal government.
That's one of the recommendations, that we expand the number of people who can be waived. Nurse practitioners and physician assistants can in fact prescribe opioids. Why can't they prescribe medications? It makes no sense.